Got it. Then I'm going to do one of the worst things we can probably do in lectures, which is just skip a million slides. Boom! Let's talk Beagle and hormones. Yeah, so again, this is probably just largely going to be sugar, pancreas, and the absence of sugar. You better. That was Almeida saying she doesn't know anything about thyroid. There we go. Timestamp 42. I just want to put you on blast. There you go. And then you can even see here. Now this is Mr. Fearon's, one of Mr. Fearon's earliest presentations. There's my disclaimer, Mr. As you were like, didn't you tell me not to do all these things you do? I'm like, brother, this is little baby Mr. Fearon here. It is, however, beautiful coloration.
I will say I took at least more than 50% of my slides and I just put them as comments.
Yeah, good. Yes, my prince. Yes. That's right. Be just like me. Okay, pancreas. Now, we'll learn during our abdominal emergency chapter about the GLASS acronym and about where the contents of our abdominal stuff is. For now, know that the pancreas here is one of our organs that is going to dictate a lot of how our body handles sugar. Now, I probably should have led with this. I do not care that you know about alpha and beta cell terminology. I, however, think it's super easy because glucagon's got an A in it and insulin is a beta. So all I mean to say is, here's what I do need you to know. The pancreas is an organ that it's in the abdomen, not the stomach, of course, because the stomach's its own organ, and that in that pancreas are these little, I think, German things, tissues, cells called the islets of Langerhans. Now, will you look that up for me, Mr. Harris? What are the islets of Langerhans? Is it a tissue, is my guess? Now, what I can say for sure is that if you said the pancreas creates glucagon and insulin, I'd say yes. But my follow-up question is, where does it do that? And you would answer, islets of Langerhans. That insulin and glucagon are created, they're hormones created essentially from the islets of Langerhans in the pancreas. Now, you've not often heard me get that specific on anatomy. Why do you suppose I am here? Because I saw that sumbitch on the registry. It asked me where glucagon and insulin were created. Now, I can't remember if it was a medic registry or an EMT one, but I saw it, so you got to know it too now. Sup, G?
Where what is created, the glucagon?
Ignore her, that's what I do. Yeah.
It's obscurely placed in your mind because it's obscurely mentioned. It says it's clusters of cells in the pancreas.
Okay.
It's patches of endocrine tissue.
Oof, okay.
It is regions of the pancreas, all of which that produce hormones, including insulin and glucagon.
Okay, so to summarize thank you so much. You just make my life better in every way. To summarize it, I think it's fair to say that the pancreas has islets of Langerhans and that those create insulin and glucagon. Please don't ask me more about it. There you go. Now, these are the primary two facets for hormones for regulating our blood sugar, and we'll talk about that in a second. Make sure that you know normal blood sugar ranges. You see how this says 70? That's wrong. The reason it's wrong is because these are pretty fluid concepts. I've seen a million different things. Your book says 80 to 120, and I'm okay with that. That's a normal adult blood sugar range, 80 to 120, because that's what your blood pressure is 120 over 80. That's easy to remember. I'm okay with that. I learned 70, that's why you see that there, and year after year I've yet to correct it. That below 80, not 60, below 80, is going to be hypoglycemia, and that above 120 is hyperglycemia. Roman, if you were at 100 blood sugar, would that be normal? Yeah. If you were at 121, would it be hyperglycemia? Yeah. Are you in danger? Not really. Your heart rate is 100. That's within a normal range. Your heart rate is 101. Are you in danger? It depends. I mean, and the same thing is true for sugar. So it, give or take a lot of these vital signs, I think we can kind of bleed about 10% of that number and not be overtly concerned, but it should point us in a direction, right? Like, yeah, so 60 is a normal low end for a heart rate. 59 may not be scary, but it does raise an eyebrow. Why on earth have I fallen outside of the normal heart range, right? Now, there's a lot of things you'll hear me kind of reacting against or pushing against. A lot of misconceptions. Often we hear Atrovent, for example, described as, oh, well, we give that in conjunction with albuterol because it dries people up. Well, I want to remind you that we give albuterol because it encourages the sympathetic nervous system, and we give Atrovent not because it dries you up, but rather because it discourages the parasympathetic nervous system. So as much as albuterol is saying, hey, bronchioles, dilate, since our normal presentation of parasympathetic nervous system is constantly whispering, hey, constrict, 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 Atrovent stops it from doing that, okay? So there's a bunch of different things. I hear in the field all the time, people are like, oh, we give Atrovent, right, to dry people up. And I'm like, no, I mean, it kind of does, but that's not why we give it. That's like saying, this house is on fire, I threw a glass of water on it, and it didn't go out, so therefore water doesn't put fire out. And I'm like, well, in the right way and in the right quantities, it would, right? Anyways, you'll hear a lot of sugar stuff. You'll hear them say things like, look, if your sugar is high, then the solution to pollution is dilution. Okay. Yes, that statement is true. No, it does not apply to hyperglycemia. We'll talk about why exactly, okay? Now, there is, you also mostly don't need to know these words or definitions. Now, depending on how your brain works, sometimes I think understanding the words and definitions is the easiest way through, but you don't need to know all these G's of sugar use. This is my G stance. Because I don't record video, I'll just have to tell whoever's listening that I look gangster as hell right now. Now, there's a couple of them in here that you do have to know for sure. You have to know what glucose is. Glucose is sugar, a sugar. Not like Henry, he's my sugar, right? Now, specifically, most of our intake and most of our glucose creation is from breaking down carbohydrates. And so, more to the point, this glucose is largely the digestion of carbohydrates. You also need to know insulin. Where is insulin made?
Islets of Langerhans.
Yeah, but you gotta say it with some stank on it.
The islands of
Langerhans, yeah.
German.
Is it? Is
All Langerhans.
yeah? Is it?
Yeah.
Langerhans. Yeah, it's good. Okay, there you go. Okay, so we need to know what insulin, that it's created specifically in the Langerhans of the pancreas, right? We also need to understand concepts about what it specifically does to your blood sugar, not to your cellular sugar. Very different concepts. We also need to have a familiarity with glucagon. Where is glucagon created? That's right. Well done. Okay. I will not. I'll probably hand this out once I have time to edit out all the stuff you don't need. The slides, that is. Here's what I want to break down for you and why I kind of say, look, yes, gluconeogenesis and glycolysis, these are strong words. And they are the correct words, but sometimes I think using the right words can be more harm than good. Let's kind of walk it back to a moment. Here we are eating our pre-Sabrized or a watermelon and some rice. I don't know. AI. Clearly. In any case, when you eat things, digestion is going to break that down. Right? It's breaking down a carbohydrate in our stomach with the acid. It's going to be absorbed through our small intestine, and then so we're eating through our mouth, The food is turning into mush. Digestion is taking our stomach and turning that mush into glucose. You with me so far? After digestion, we have absorption. That's where our small intestine is taking in that glucose into the blood. Right? I eat food, turns into glucose in my blood. Now we got to talk about what happens to that glucose. Glucose in my blood does me essentially no good if it stays there, right? When you breathe in, what are you taking in? Air, which is comprised of what? Oxygen, nitrogen. Yeah, absolutely. Now we need that oxygen because it's going to go down into our alveoli. Is it doing us any good there? Not specifically, depending on how you frame the question or the idea. Well, okay, so it goes from the alveoli and then it goes into our blood. Now our oxygenation is fantastic. Are we okay? Well, it does us no good immediately or inherently if it's just in our blood. Where does that oxygen have to go? Into the cells, if you want to live. And I recommend that you do. One of my favorite quotes of all time. Full Metal Jacket? Full Metal Jacket? Full Metal Jacket? The dead know only one thing. It is better to be alive. Insulin is the key, right? Now, oxygen doesn't need any help getting into the cells. It just flows into the cell, through the cell wall. It flows past the cells of the alveoli. It flows through the arteries and veins, in a sense, back and forth. It's got no issues. But sugar is too big. Incidentally, sugar makes you too big. But sugar is too big. It doesn't just flow freely into cells. How it does that is with a key, and insulin is that key. No insulin, no open cell. It doesn't matter if you have a bunch of blood sugar, it doesn't get in the cell. Now we remember from back in a shock discussion that we need ATP and we need energy to be alive, which is oxygen plus sugar, right? And we're now also learning that we can't complete the cellular metabolism if we don't have insulin. Alex, why can't I complete cellular metabolism even if I've got high sugar and high oxygen?
You have too much, right? Like, as in, is it turned into acid?
No, essentially. Maybe I'll ask it again in case it was misunderstood. I have a lot of oxygen in my blood. I've got a lot of sugar in my blood.
Oh, it's not getting to the organ.
It is not getting to the cells, the tissue, and the organ, essentially, yeah. And it's not doing that if I don't have the insulin to open the door in the first place, right? Yeah. Not for nothing, but this is glycolysis. I don't have a test question, I don't think, where I ask you to know what glycolysis is, but it's super cool. So there you are. This is the process of glycolysis. It's when the sugar goes in there and gets broken down. Glycogenesis, not just your favorite drummer or your favorite book. When we have sugar in our body, it is being used essentially for one reason, and if it can't be used for that reason, then it is stored. Lauren, why do I need sugar? Yeah. Without oxygen and sugar, I don't live. My cells don't metabolize, my arms don't arm, my legs don't leg, my liver don't liver. I need it to be alive. Now, if I eat a Snickers bar and my body says, well, all you're doing is 2 cartwheels and jumping up and down, all you need is half that Snickers bar, you don't just pass the other half of your Snickers bar through your urethra. Your body says, wait, what if tomorrow there is no Snickers bar? Or in Henry's case, what if there's never a Snickers bar? Because he is allergic. So what does your body do with that other half of the Snickers bar? It stores it. The question is where? Well, it stores it in one of 3 places, and it prioritizes your liver and your muscles first. I do 2 cartwheels worth of Snickers bar. Instead of passing it out like a bumpy log, I store it. And where do I store it? First in my liver and in my muscles. And the reason for that is because if I was like, yep, hey body, just 2 cartwheels today, that's all my plan is. Wait! 3 cartwheels is what I need. Well, then your body's going to say, okay, well, then I better get that energy fast. And guess what? It comes out of the liver and the muscles pretty quickly. That's why it stores it there. Now, when we store it there, that glucose becomes glycogen, like a generating sugar store. That's kind of how I remember it. It's glycogenerating your stores. Sebastian, what hormone is used to open my heart cells to allow sugar to come in? Insulin. It is the same thing that opens the cells in my liver and my muscles to store that sugar.
What, the insulin?
Insulin. Insulin is the in key.
So that's like how the sugar, extra sugar, everything gets stored.
Yep. To use sugar, to use glucose, we need insulin to open the cell. To store glucose, we need insulin to open the cell. Glucose doesn't get used or stored in cells without insulin. Roman?
You keep saying open the cell.
Yes, sir.
I remember you and I talked about this last time. Is that like cellular dilation in a sense? Is that a way of looking at it, or like how should we go about looking at that?
I'll draw on the board because I'm not well prepared for this. Oh, no, I'll have to do it up here so you can see it. This will definitely help. I don't know. Maybe it'll cast it. Probably not picking it up. Here's what I'm going to draw. Here's how we think of a cell, right? The truth is that that you are just a giant pile of electrons, really. You think you're pushing against this wall, but really your hand electrons are pushing against the wall, that we're all empty spaces held together, right? It's not so simple as to say a cell is just a circle that is unending with a perfect wall in it. Truth be told, it's got a bunch of fenestrations in it. This circle will never go away. This is an eternal circle. Okay. In any case, your cells are more like this, that at some point they have openings in them of different sizes in a cell. Some of them are called channels, some of them are called pumps, some are just the natural space between the atoms as they don't fully touch. What I'm saying to you is when I say open the cell, it's because oxygen can just flow through. The molecule's so small, it can just go into a red blood cell, don't need any help at all. It just kind of sneaks between the molecules that make up a red blood cell. It doesn't need help opening the cell. But sugar is way bigger. The sugar molecule is so big, in fact, if I just draw this, giant sugar, it cannot slide through the molecules of your red blood cell. Something's got to open up to let that sugar in. And so in a sense, the insulin is like a key that opens a specific door to let sugar into the cell because it can't just flow freely. Yep.
So how does the insulin know when to be released? Are there like receptors in the body to just know when it detects it, or that might be a whole...
No. I'm sure that it's just a very simple answer that I don't know the exact word of. Okay. I'll probably look into it and be like, yeah, it's a chemoreceptor that just literally detects sugar. I don't know or remember.
Okay.
Does that help at all, Roman?
Yes.
Okay, it doesn't flow freely because it's so big. You have to get all cells open first, and insulin essentially does that. Okay. So, is insulin used to open cells to create energy? Yes. What hormone is used to open cells to store energy?
Insulin.
Good job. There you go. Now we call it glucose, it's the breakdown of the food we ate into a smaller form, right? Into a different form. But it's not stored as glucose. What's it stored as? Glycogen. Now specifically it's stored as glycogen in the liver and the muscles. It can be stored in the fat and a different name. Okay. If insulin is the in key, glucagon, to be gone, is the out key. Now, based on that description alone, if I told you that insulin is how we store glucose as glycogen in the liver, what does glucagon do? It releases it. Now again, glucagon is a key, just like insulin is. Is insulin sugar?
No.
No, it is not. Insulin is the key. If I have really high insulin, my body's not gonna, it can't use that as energy. It needs sugar as energy, right? Insulin opens the door so that sugar can get in there and be used or stored. Glucagon is opening the outdoor. So if I said, hey, I've got a bunch of stored sugar as glycogen in my liver and I want to get it out, what does my body create from the islets of Langerhans to get it out? Glucagon, right? So in summary, it is our preference as EMTs in a hypoglycemic patient to administer a carbohydrate. Glucagon isn't a carbohydrate, but oral glucose is. It is better and easier on the body and simpler to send sugar down the grocery hole so that it can turn it into glucose and be utilized in the body. Glucagon very specifically isn't adding sugar to the body, it's taking sugar from where? The liver and the muscles, which means if you don't have sugar stored in your liver and muscles, does glucagon do anything? It does not. And so that is one of the bigger miscommunications, I think, because if I said you have low blood sugar, what should I give you? You say glucagon, that might be true, but it's not because it's adding sugar to the equation, it's moving it. If you don't have it in the first place, then it will do nothing for you. In fact, it could be very dangerous. I told myself as a medic, when I learned about it, that I would try to go my entire career without giving it. I'm like, I can get a line. I've done IVs and boobs before. I can get a dextrose flowing. Well, a couple times I couldn't. Had to give glucagon, and it worked really well. So I don't think it's something we need to be afraid of, but it's definitely something we need to be conscientious of. Was that Stephen? You had a question, or?
Yeah. So I thought, like, at what point, or if it doesn't at all, does the sugar ever get stored in the fat cells?
It does.
When does that happen?
Amazing question. Amazing question. Let's look at it like this. Wow, nice. Bailey, high five, Stephen. There you go. I don't know how to go over. Oh no, I can't. Everything's doomed. Ha ha. No. Oh, I don't click. That's what it is. Okay, let's kind of picture some buckets, I guess. Let's picture buckets.
Is that going to be part of the YouTube video?
I don't think so. You're just going to have to use your imagination.
Okay.
In the future, I can do that. It hadn't occurred to me it would be valuable. Okay, let's do like this. Yeah, get it. Say it, Aiden.
It's like the first one. If your liver fills up, it overflows to the muscles, and if they fill up, then it goes to the fat. It's like the waterfall kind of effect.
Mm-hmm.
Or,
Now, some of the stuff I wrote on here is absurd to the point as to be very misleading. I realize that now, but I can't stop myself sometimes. So, in a sense, exactly like Aiden is saying, if you ate sugar, if you ate energy, or sorry, not energy, if you ate sugar, it would immediately be utilized as energy in the cells in the way that you need them to. But let's say that you ate a Snickers bar, an entire thing, and really, why wouldn't you? But your body only needed 50% of that sugar to live. What it would then do is flow into the next place that it needs to go, which is your liver and your muscles. Why does it flow first into your liver and your muscles? Oh, fastest. I don't know if it's first or not. That's beyond my understanding, but it's definitely the fastest to withdraw from, probably to add to. And so what it does then is it says, okay, look, I only needed this much energy. My energy bucket is full. Therefore, the rest of the Snickers bar will start filling up my liver, start filling up my muscles. And it's like, oh, okay, I have as much glycogen as I can possibly store in my liver and my muscles now. Well, you still got a third of a Snickers bar. So it goes down here into the fat. So if the question became, why do we get bigger when we eat sugar? It's because your body wants to live. Stupid.
Oh, so it just moves it and it's
It will,
stores that.
and it can store, that bucket is misrepresented there.
That's the biggest one.
That bucket is infinite. Now, in some cases, it's a bit of a champagne problem, right? Like if my wife starts storing this on her hip or various other places, I ain't mind that so much, right? But it's not that she's trying to attract a mate, it's she's trying to store sugar, right? And that's essentially what's happening. This is the process of glycolysis here where we're storing energy. This is the process of, well, let's just say the most important word here is glycogen, that it's storing glycogen in the liver. Oh, that was a good question, Stephen.
So when it goes to the liver and the muscles, what is, like, how much can it go in there?
What's that?
Like you said.
I don't know. I asked ChatGPT on the way in this morning. I was like, hey, is there like a number or a percentage or a whatever? And it was like, no. So I don't know. I don't know how much can be.
Like, because you said fill up the bucket, so I was just curious.
It is a proverbial unknown. I would say this. I don't, it is more important to know that it does it, not that it knows how much it does. So in a sense, if I eat food, it uses some of it for energy, it uses some of it to fill up my liver and muscles, and when it's, if there's some left over, it fills up my fat. Sam?
Going back to giving glucagon.
Yeah?
Ms. Reimer had a good analogy she gave our group, which was glucagon basically opens the pantry doors, gets everything out, but the only problem is now there's nothing in the pantry.
Well said.
So you're talking about how you have to monitor.
Yeah, that.
Levels will go up and then
Yeah, that's perfect. Yeah, and so what Sam's saying is that the parallel here is that glucagon works like your liver is a pantry in a sense. That if you're using glucagon to raise a blood sugar, again, you are not adding sugar to the mix. You are moving it from the pantry, or the liver in this case, to the cells, and so you can run out of that. The biggest catch here is I got a test question coming. This has the word emaciated. What does the word emaciated mean? Yeah, real thin, right? Anorexic, perhaps, or like your intake is just very low, right? You have a patient that's very thin, maybe to the unhealthy sense. Their liver and fat cells are storage is low. Glucagon might be dangerous for them
How come?
because it might deplete the only stores they have. Now, don't get me wrong.
Oh, cause yeah.
It's just taking it,
Yeah.
right? It's taking all the food out of the pantry, and if there's nothing left in the pantry, buddy, if you don't add sugar to the mix, you are doomed. So I don't mean to scare anybody about glucagon. You shouldn't be, especially as an EMT that has, patients they can't give oral glucose to. Dude, send glucagon. But here's what I always say. It is not uncommon for me to do refusals for known diabetics. Sebastian's a known diabetic. He doesn't eat food, therefore his sugar goes down and he passes out. I show up at his house, stick him full of holes, run sugar into his veins, and he wakes up. And the first thing he says is, oh, please don't take me to the hospital. There's no medical mystery here. I didn't eat food. I'm a diabetic. I passed out. And I'm like, no problem. That don't bother me at all. You got no other symptoms. Your vital signs are cool. Sign a refusal here, right? Now, I still encourage transport. I say, hey, look, if you're living your life in a way where you're passing out because you're not eating sugar, you should go to the hospital. You should talk to somebody. You should draw your blood and make sure that this isn't something else. So I'm not saying I encourage refusal, but it's one of the only situations where I'm like expecting it to happen from the beginning. A known diabetic, whatever. I get it. I used to, in the beginning of my career, I'd trap people. They'd be like, oh, my husband, he's diabetic. And I'd be like, okay, I'm gonna get him loaded up. I'm gonna start treating him on the way to the hospital. Then he can't say no. Well, he can say no. I just end up leaving him in McDonald's parking lot instead of driving him home because ambulances go forward, not backwards, right? And he'd be like, what the hell is he taking me for? All I needed was a sandwich. So, on that note, essentially, we're going to talk about some of the hypoglycemic emergencies. I'll need you to understand 3 different types of diabetes mellitus. Mellitus? Mellitus? First of all, this. Diabetes. That's a meme. I can meme. Probably a Vine, actually. Diabetes 1 is an autoimmune disorder, and to define that, it means your body attacks itself. Your body is crazy. Your body, people get diabetes 1 for this reason. One day, there was an islets of Langerhans. And the body looked at it and said, I think you're going to kill me, so I'm going to kill you first. And so your body's immune response attacks the islets of Langerhans and kills it dead. Good job, we live to fight another day. Except for, you die without those. Stupid body. That's what diabetes is. Diabetes 1 is your body attacking the thing that makes insulin specifically. It attacks the islets of Langerhans and the part that makes the beta cells.
And those regenerate.
No. That's why you live your whole life with diabetes. Yeah, so your body can't make insulin, or at least barely makes insulin in diabetes 1, because it attacked the islets of Langerhans. And so we would expect these people to be younger than older. It is rare that you develop diabetes 1 late in your life. Usually if this happens, it happens pretty early. Not always from birth. It's not what they call congenital, but I would expect it sooner than later. These people require daily insulin. Why is that? Because they ain't making it. You'll hear these terms in the field. You'll go to somebody's house, they'll be low blood sugar, you'll wake them up like a wizard. Just poof, little sugar, suddenly they're all better. And you're like, man, I'm EMT. It's awesome. I love it. I loved it. I love starting a line, throwing in dextrose, and dude's life is all fixed, and you're like, boom, making things happen. They'll wake up and tell you, well, I'm a brittle diabetic. This isn't my fault. Listen to me when I tell you, yes, it is.
What is brittle diabetic?
Brittle is like glass, fractured, breaking, easy to break. There is such a condition as a brittle diabetic. There is such a condition where your diabetes is so hard to manage that there's nothing you can do. Sometimes it goes up or down. You just can't. Okay, that is such an infinitesimally small portion of the population, yet every third diabetic I know says it. Look, you already know, Jack, are you a diabetic? Congratulations. What would cause you to be low blood sugar? If you just didn't eat. Okay, there's 50% of the equation. People have hypoglycemic emergencies because they either A, don't eat enough food, or B, have injected too much insulin. That is it. You walk up. Ready to play a game with me, Bailey? All right, it's Bloody Knuckles. Okay. I have arrived to find a patient who is hypoglycemic. Because I am a witch, I know that it isn't because they didn't eat enough food. What is their problem? So low blood sugar happens for only 2 reasons. Jack, if it's not too low of sugar, then it's too much insulin. That is it. Insulin lowers your blood sugar. Not having sugar in your blood lowers it too. Steven?
I know they say like if people are like starving for a amount of time and then you give them food and they eat too much and die.
Yep.
Does that have anything to do with this?
No, that has to do with the literal shrinking of their stomach.
So does it eat their stomach ruptures or something?
Yes.
Okay.
They're like we saw that a lot in the concentration camps.
Yes,
Yeah. Man.
These are so type 1, type 2, and gestational are all hypo.
Gestate. Mm-hmm. Gestational.
I don't know.
Okay. Oh, okay. I don't know what that error was.
Body came off.
Testing. Come in. Okay. Okay. You had asked me a question. I'm so sorry, Lauren. Give me. Oh, why? No, I thought you said gestational diabetes and diabetes.
They're all hypoglycemic emergencies, right? Or that's what they normally lead to. Hypoglycemia, like low blood.
If you still have that question at the end, we'll ask it, but I think it will resolve itself pretty neatly here. But if I start in on it now, it's going to jump all over the place. It's a good question, but I think we'll answer it quickly. Lauren?
So for the diabetic emergencies, it's either that they didn't eat or could have, you said like they injected Like, would it be like they injected too much of their own medicine?
Or
If none of us, no one has to talk about their medical history in here, and probably you shouldn't, because I will use it. But like all of us are creating insulin. None of us have insulin pens or pumps or whatever. So like the only reason a person's blood sugar would be low if they were taking in enough is if somebody put insulin in them.
If it's too.
Your body will never just overproduce, so far as I know, never overproduce insulin. So to answer your question, it's not diabetic emergencies. It's hypoglycemia is either because of too low of intake or too much insulin hard stop.
For
Low blood sugar.
I think I was like getting confused and thinking it was like high, like if they ate too, like if you're diabetic and you eat like too much sugar or something. Obviously wrong on that.
Kind of. That's why I changed the word. You said diabetic and I said hypoglycemia. Low blood sugar is because of too little food or too much insulin hard stop. But diabetic emergencies can go all over the place. We'll talk about that.
Normal people also have low blood sugar. Is it just not as bad as diabetics? Like
Yeah,
eat throughout the
like
day?
Jack, arguably normal. And if he didn't eat, his blood sugar would get low. And if he didn't ever eat, he would die. And part of that reason would be because without sugar, he doesn't have ATP. I felt so bad. Shannon got corrected in a lab, and I had to kind of choose whether or not to like lambast. But Shannon's response, they were like, "Hey, your patient is hypoglycemic. What do you think they look like?" And she said, "Do you remember? Shocky." And the adjunct said, "Not quite." And that's like, no, definitely. Definitely. If you don't have half of the equation that colorates your skin, which is, like somebody describe hypoglycemia in a way that does not look like you're in shock.
You really can't.
No, other than their blood glucose level, not really. So yes, it is shocky. Now, you might be more diaphoretic in shock and more clammy. Okay, in hypoglycemia, I get that. But I am okay with you being like, okay, that guy looks like he's in shock. Oh, his oxygen and BP is fine.
What's his blood glucose?
What is his blood glucose? To the point where I'd like it for you as a class to be like, why isn't it like ABCs with a G in there? Like, that is so integral. Feels like break time.
Too much insulin. You didn't eat enough.
They didn't eat enough to the blood sugar tank. Or their type 1 diet, or I don't know.
Had too much insulin.
Deep water for me.
Just do it instantly. No food, no insulin, too much insulin.
Where do you go to get that again?
Right? Sam, why would somebody be low sugar? Or? I love it, not enough food. Now, there is such a thing as a brittle diabetic. We do need to be sensitive. I don't mean to write off like, I don't know what your problem is. Look, there are brittle diabetics, people where it doesn't matter what they do, they fall into diabetic emergencies. I'm sensitive to that. But what I've experienced far more than that is some fellow walking down the street getting in a fight with cops, and he's like, well, I remember literally talking to a fellow about this. He was like, this crap, cops are always beating me up just because I'm low blood sugar. I said, brother, if you get in low blood sugar to the point you fighting cops, you ought to carry a sandwich in your pocket. Like, what are you talking about? Lucky for you, that's a cheap management source, you know? Now, it's not always that easy. Of course, it's not just about the sugar, it's about getting the insulin in. So let's have a quick conversation about insulin. Is insulin in your scope? No, it is not. You cannot assist, or you should not. It's probably a more important thing. But here's the interesting thing. Is anybody surprised to hear that in a hyperglycemic emergency, that the solution to their problem is insulin? Hyperglycemia? In you go to the hospital with hyperglycemia.
I thought we were doing a hypo.
We are.
Never
But I got to talk about insulin.
Never mind.
Come on, follow. What's up?
Well, I'm assuming you're going to look at what you're just talking about.
Maybe. Never tell. Yeah, okay. If your sugar is low, it is because one of two things. Either because you do not have enough what? Or you have too much, because too much insulin will drive your sugar down. How is it doing that? Get out. Parker, get out. Saving Private Ryan? My man. When I give, if Aiden's sugar is 100 and I give him a bunch of insulin, it might go to 50. Where did it go? It did go down conceptually, but where specifically? Muscles is part, liver and muscles, but it went into a bucket before that. Cells. If I give him insulin, it is going to then allow him to use it as energy. Whatever's left goes into his liver and muscles, and whatever's left go into that booty. Right?
The difference between these two, just the concentration.
I really don't know. Here's what you need to know, is that if a patient with diabetes, where their diabetes 1, where their islets of Langerhans have been destroyed, therefore they don't create insulin, therefore when they eat sugar it stays high, so they have to inject insulin to take their sugar down. Now insulin comes in basically two forms, I guess. One is short acting, one is long acting. Why do I care that you know that?
Last known normal.
They affect people differently. Last known normal.
If you go to like a patient and they have like a little insulin thing, you need to know how long they last.
Largely, it revolves around treatment and refusal. Yeah, is that where you're at, Sebastian? Tell me about it.
Because like if they have long-lasting insulin and you try to give them sugar, it's just not gonna do anything.
I'll be fighting it for a day. If I show up, and Haley, they're both these two. Haley and Kendall are there. They're both diabetic. Somehow had a diabetic emergency on the same day. They played a weird game where you spin the insulin pen and you just hit each other with it, right? They're crazy girls. I don't know what their deal is. But in either case, like one of them got Humalog and the other one got Lantus. Now there are a million of these things. These are the ones I carry you know. You have to know these things. I know it's not in your scope, so what? Now, one of them got stuck with Lantus, the other got stuck with Humalog. I show up as an EMT. I give them both oral glucose. They both get better. I say, hey, when did you guys play this weird little game? And they're like, I don't know, about 6-7 hours ago. I say, well, okay, well, I need to take you to the hospital. And they both say, nah, I don't want to go. One of them has insulin that's going to last for the next 24 hours. And the fact that they're better now is irrelevant. That medicine is on a long timer. The other one got 5 hours. It's already gone, in a sense. So I care that you know, because what I don't want to happen is for you to fix somebody's problem and then say, look, I'm fine now. And you're like, well, what did you take? And they say, well, I took Lantus. And you're like, when did you take it? And they're like, just before I went and took a nap like 2 hours ago. I'm like, okay, you are going to be fighting this problem for the next 24 hours. You need to go to the hospital or have somebody here that can monitor your diet, dude. So make sure that you know the difference, superficially that there is a difference between long acting and short acting. I picked these ones because not only are they popular, but they're easy to remember. Lantus, long acting. La 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 la. Right? There you go.
So what exactly are they fighting? I'm sorry.
No, you're okay. Think of, do I want to work it like this? Like if you take in a bunch of heroin and I want to fix your problem, what med do I give? Narcan, okay? Why would you start breathing? Well, only if the Narcan beats the heroin, right? If I just give you if I give you 0.01 milligrams of Narcan, the heroin's going to win, right? The heroin's going to last longer, it's going to last stronger, right? So I have to kind of play this game. It's just like epi and anaphylaxis. I just give you a spritz of epi. Do you get better? No. Like we have to give you enough med to fight the problem and see which one wins on a long enough timeline. And so if I'm giving you sugar, but you got insulin that's driving your sugar down for 12, 20, 24 hours, I'm going to have to keep giving you sugar.
So you need to go to the hospital and monitor.
I recommend it for sure. I recommend it for sure.
Is that like you say get insulin and they're like, I don't feel good until, is it kind of like an immediate, they know when their levels go off? Like
Most diabetics specifically know when their levels are off. They live their whole...
instantly?
They feel it coming. Yeah. They're just like, woof, I need to get some sugar in. Or usually they feel the hypoglycemia. I don't know that they necessarily are identifying their sugars too high, because usually people administer insulin to themselves on a timetable, not on a feeling. Like I've known people who are like, oh, I want to go to eat at this special place. I'm going to go ahead and give myself some insulin before I go because I know I'm going to need it. But usually they just take it at night or in the morning or sometimes both. Where we will run emergencies like crazy is they're so used to taking it on a timetable, but they didn't eat today. Like, I'm late for work or whatever, I'll catch a bagel on the way, forget to do that. But took their insulin every morning like clockwork, but they didn't put sugar in, so what little sugar they had plummets. That's where we usually have the problem. Somebody took their daily insulin medication, but did not take their daily sugar intake, and so now they have a major issue. That's usually what it is. And you can usually feel the hypoglycemia. I don't know that they necessarily feel the hyperglycemia. That takes, like, if I said, hey, your patient has a diabetic emergency and it's occurred in the last 30 minutes, what do you think it is? It's hypoglycemia. It's not hyper. Hyper takes a while to work up to a problem.
In your experience, do the people who have injected themselves with insulin know if it's long or short acting?
Definitely. Yeah, usually people, unless they're a child, which is possible because we get diabetes when we're children often, they're usually experts on their medication. They know whether it's what the name is. It's often stored in the fridge because it has to be refrigerated. That's why it's not uncommon for me to go in, see an unresponsive person, me to open up their fridge looking for little bottles of insulin. Because if I find it, I'm like, oh, there it is. But yeah, usually people know. And if they don't, you can Google it.
Could a person have diabetes and not have one of these insulin pumps? Like they just take their shot?
Yes. Yep. You are either taking daily insulin shot injections or you have a pump that is constantly checking your levels and administering only exactly what you need, which is probably optimal in every way. Now, one of the reasons I wanted to bring this up is, what are these? Yeah. One of the other major diabetic miscommunications, and I heard it in your lab, an adjunct very proudly described something to me, is that, on the left, we have sensors. On the right, we have pump patches. These are sensors. Those are the pump and the sensor, but they look almost identical. And I've seen before where they're like, I can't find the pump anywhere. And I'm like, it's probably that little square. And they're like, that's the sensor. And I'm like, sometimes they're that small.
Do you take it off for sometimes?
Hell no, you don't take it off.
It can malfunction though.
It can. Yeah, I mean, don't get me wrong. There are many a time where I've paused a pump, and despite what I think another common sentiment is it's outside of your scope, don't touch it. I'm like, that's like saying heroin is outside of my scope. If I show up, and somebody's got a heroin needle in their arm, and I'm like, can't touch it, not in my scope. I'm like, it's what's killing them. If they're on fire, I'm like, I didn't go through fire 1 and 2. Outside my scope. Like, no, I'm definitely going to start spitting. Yeah. So, yes, they often have these little sensors monitoring your levels to be able to trace to a wire, but as we kind of, careen into the future here, sometimes that's all it is. It's just a 3 to 5 day insulin patch pump they just replace. It has no wire, it has no hip thing. And unlike I've heard many times, I do think that it is completely appropriate to pause it or sometimes disconnect it. However, knowing how and why is a couple of extra levels of science. It's not so simple as to just say, well, I get the heroin out and then they get better. Because heroin is, let's just for sake of argument say, only bad, right? Like, yes, it stops you from breathing, but your body doesn't use heroin for any physiological process. Okay, insulin is killing you because it's going haywire and it's dumping into your system. But if you turn it off, and now it can't use sugar. So if you're going to interrupt these pumps, it's usually temporarily. Basically, this is what happens where I interact with a pump. I show up, a person is unresponsive, I check their sugar, and it's low. I don't know why it's low because I don't know jack diddly squoot about their pump. So I give sugar. They don't get almost immediately better. I pause the pump. Because I'm thinking, well, I'm giving you sugar and the insulin is just wiping it out. So I pause the pump. Then they will start to get better because the insulin is no longer getting dumped in. And then I'm like, hey, princess, please fix your pump. So they'll be like, oh, yeah. Oh, no, whoa, how did that happen? It's set to 20, should be 2 or whatever. Like, I don't know anything about their pump. So if they wake up, I'm going to immediately point them to it. Like, something happened. They'll be like, ooh, let's just turn that off. I don't know what the hell that is. So it's not a good idea to just walk up, rip it off a person. First of all, you don't know how it works. Second of all, if you don't, we know their body doesn't make insulin. If you disconnect that, then they can't use sugar even if you give it to them.
They need insulin to make sugar.
That's right. And so I would say that, look, I know it's not in your scope, but if basically you walk in, if they can take glucagon or oral glucose, then you should do that. If it's not working, consider pausing their pump. They will probably come around. If that doesn't work, sugar wasn't your problem.
Right. Something else.
This is fun. You having fun? It's good. It's a good learning.
It's a lot though.
Getting learning. Learning all over the place. On the floor,
Is that like the only like type
all over your arms.
sensor, like that main one? Is that like the most common one?
I would say that if you told me to look for a pump, I would immediately go behind the bicep.
Okay.
But I have seen them on the lower back too. I imagine you can put them basically anywhere, but that's where I would look. But I hope, and that's why we run that lab. That's like one of your first labs where a medical patient requires a physical assessment. And it's probably day one where somebody is like, is this why you've been saying I do physical assessments all the time? And I'm like, it's part of it. Because even medical patients got physical presentation. Okay. Let's see. Pam. Why does someone get diabetes mellitus 1? My grandma has DM1. How'd she get it? Nada? Henry, I have DM1. How'd I get it? Autoimmune. What does autoimmune mean? If I have diabetes 1, my body attacked the islets of Langerhans and I either can't or release too little insulin. That's diabetes 1, full stop. Nothing else. Usually happens early on. We usually discover it because without insulin, your sugar goes up. And so you get some 2-3-year-old with some weird sick-like symptoms. You check his sugar and it's 400 and they're like, what? Well, we just learned he can't make insulin. You discover that pretty soon because you can't live without utilizing sugar. Now, diabetes type 2 is mostly, what do you call it? Lifestyle. Yeah. It's not all lifestyle. There is a genetic component to it, for sure. But if you left this class thinking diabetes 1 happens due to an autoimmune disorder, nothing you can do to change it, and diabetes 2 is what you eat and whether or not you move, that is almost always going to be correct. One of the biggest confusions about these two, and I almost wish they were different names, because what usually happens is people say, well, diabetes 1 means no insulin and diabetes 2 means too low of insulin. And diabetes 2 is not the issue of too low of insulin. If I eat a Snickers bar today, my body uses it as energy, stores it in my liver and muscles, then stores it in my fat. If tomorrow I eat 2 Snickers, it's going to say, well, I need twice as much insulin now because I got to use twice as much, I got to store twice. And so the day after, I have a 3rd Snickers. And my body says, okay, well, I'm maxed out on insulin. I'm just going to keep producing the most amount of insulin I can every day to match your dietary habits. After a while, the volume gets turned down. Your cells start to become insulated against having a perpetually high insulin levels. Desensitizes to the level of insulin in your body. If you keep forcing your body to create enormous amounts of insulin every day, it will become less effective. That's what type 2 is. It is a desensitization to the insulin. Not too much, not too little, not too little insulin. It's actually too much. Yeah.
So, before this class, as a layman, I
Mm-hmm.
always thought type 1 was like mostly at birth.
Yes.
And then not type 2 is like it happens as you're living your life.
Yeah, that is accurate. To say, if I said you have a 1-year-old with diabetes and a 50-year-old and they both just got it, which one did they get? The 1-year-old is diabetes 1 and the 50-year-old is diabetes 2. It's not always true, but it's often that. Can you get diabetes 1 later in life? You can, but if it happens, it usually happens early. Can you get diabetes 2 for reasons that aren't lifestyle? Yes, but that's so rare. And even when it is genetic, you still can have major control over it because of your lifestyle.
Can you fix it by changing the lifestyle?
I don't know. I'm almost sure yes. I'm almost sure you can fix it. Because I know that you can resensitize your cells to insulin. That with, I don't know if we'll draw this conclusion, but what it always reminds me of is hypoxic drive. Like if you have emphysema and you're not fully getting out all of the CO2, your CO2 level stays abnormally high and your body becomes desensitized to the CO2 and it starts monitoring your O2 levels. Similarly here, if you are constantly forcing more sugar than you need, your body has to meet the demands by increasing insulin. It will become desensitized to that insulin. And so even though they are sometimes prescribed insulin, more often than not, they're prescribed medication that makes the cells sensitive to insulin. Diabetes 2 is not a problem with insulin production. They're producing it just fine. The problem is their cells aren't reacting to it anymore because they produce so much of it. They have to keep up with the sugar. Or I don't know if they have to, but they do. So if a guy says, I'm diabetes 2, I have diabetes mellitus 2, we know that it is not an autoimmune disorder. We know that he is producing insulin. That's right. And so if diabetes 1 hypoglycemia has low blood sugar, it is either because, well, I shouldn't make this distinction. Diabetes 2 sometimes prescribed insulin. And that's why I've been trying to kind of avoid saying, oh, diabetes is this, diabetes is that, and more just saying hypoglycemia. Because if Landon presumably isn't diabetic and I just go over there and jam him full of insulin, he will die from it. So finally. Yeah. Right, so more than anything, diabetes 2 is not an issue with too low of insulin. It's a desensitization because of the constant submission to that.
Does treatment change?
Our treatment?
Yes.
We are not treating diabetes, we are treating glucose levels.
Yeah.
So if a diabetes 1, 2, gestational, stroke, seizure, aneurysm, if they're low blood sugar, we treat it all the same. One of the things I think is particularly fascinating, oh wow, you will not look at me at all if I do that. One of the things I think is particularly interesting is even as a medic, insulin isn't part of our scope. Now, this won't appear on a test, but I think it is super duper cool. When I give you insulin, sugar's not the only thing that moves. Potassium is as well. In short, if, Almeida's sugar is too high, and so therefore she's unresponsive, I go in her fridge and there's insulin, I'm like, oh, easy, blam. She goes into VFib. Not always, but it is possible. In summary, if I just inject insulin into a person, it will cause a potassium shift, and that leads to lethal dysrhythmias. What's funny is if you go into the hospital and your blood sugar is too high, they give you sugar. Why?
Oh, to match the insulin.
To match the insulin. Well done, Almeida. They have to give you, sometimes they trickle in the sugar, sometimes they trickle in the insulin, and they also will add and adjust potassium levels. So if you ask a doctor, hey, why as an EMT don't I just give the patient, why can't I assist with insulin? He'll say, because you could put them in VFib. I'm more concerned, let them sit unconscious at a 300 sugar. That's not that big of a deal. Well, it's not that it's not that big of a deal, but VFib is a much bigger deal. So bring them to the hospital where I can kind of trickle in potassium, where I can regulate their sugar with insulin, where I can even give them glucose if necessary, so we come down on the, it's not an easy fix. It's not like, oh, I just give you insulin and then you go home that day. It's like, no, we have to kind of, is that confusion, Mr. Harris?
I've only seen that performed for hyperkalemic patients.
That's fair.
That they give insulin and dextrose
Fair enough. What are you,
to bleed out the potassium.
maybe I misspoke? What are you counteracting? Or?
So if insulin takes potassium with it, then even a non-diabetic could receive insulin and...
Oh, you're saying that if you come in and your isolated issue is hyperkalemia, they will give insulin sugar to balance out the fact that they got to, okay, yeah. No, he's more right than I am. The idea, I think, or the simple correction is like, you're not going in with hyperglycemia and they're giving you sugar.
No.
Yeah, okay, that was my misspeak. You're dead nuts.
They do it for hyperkalemia.
If you go in where potassium is your original problem, then insulin is how you fix that, which is what would cause VFib, but they don't. This is why you got to stay, right? Yeah, perfect, lovely. Thank you so much for that. Yeah, absolutely. And so in summary, it's why you can't just walk over there and shouldn't walk over there and grab insulin and just jam it. And you're like, you're already prescribed it. It's like, well, because you're going to cause a huge potassium shift, and that's going to change how their heart works. All right, here you go, little writers. This is it in a nutshell. Whatever you got to do, just make sure I'm in it. Big ducky. Okay.
Thank you.
Yes, ma'am. This is like the small version of this stuff. The cause of it is autoimmune. The onset is often birth, but not always. For diabetes 1. Insulin is little to none produced, and it definitely can cause seizures and neuropathology, or breakdown of your neurology, numbness and tingling in your hands, destruction of your renal system, destruction of your optic nerves. Having high blood sugar causes a lot of destruction in your body. We write it off sometimes because every 4th person we know has diabetes, but it is one of the most insidious disease processes because it tears apart everything else, just like hypertension.
Gestational, is that just if they're...
When you gestate in a baby. Diabetes 2 is largely diet and lifestyle, and its onset is often adulthood because that's where we're starting to, our life choices aren't adjusting and our metabolism is. You might have low insulin production, but it's predominantly due to the resistance of the cells because of all the insulin's being subjected to in the first place. Yes, you can have seizures and neuropathy like you can in every instance. Gestational diabetes is a little bit different. Put pretty simply, there you are walking along as a girl do be, gets a baby big time, starts growing it even bigger. The placenta will start releasing hormones necessary for life. Well, progesterone and other hormones that are released have a way of desensitizing our cells to insulin.
How common is that to happen?
Very uncommon is my guess, because I don't think I've ever seen it, but it could just be anecdotal. If I get a pregnant woman whose sugar is high, I'm like, do you have diabetes? And she says no. I'd say, well, you do now. You have gestational diabetes. And if, as so often is the case, getting pregnant is what got us into this mess, what do you suppose the solution to the problem is?
Getting that baby out.
Yeah. Having the baby. The mic only works so far. That's probably for the best.
Does the diabetes stay with them after they...
No, ma'am.
Oh.
Because their issue in gestational diabetes isn't insulin and sugar and stuff. It's the hormone they're making to grow a baby. And so when the baby's gone and off to college, experimenting and, as babies do in college, then your body no longer needs to make these growth hormones, and therefore it's not pushing around your cells and insulin sensitivity, right? Cool. Here's the reminder, because it's a very common misconception. People are like, well, do you need me to go back? Well, my blood sugar's at 400. Why am I confused? I have enough sugar. Okay. Having a high SpO2 does not mean that you are perfusing well, right? You remember that? So your oxygen level is high. Great. Is it in all the tissues and organs you need? That's a different question. Your blood sugar is 400. Well, first of all, that's too high. The question is, why is it that high and why isn't it getting used or stored? Right? So in either case, high blood sugar, which is low glucose, or low blood sugar or high blood sugar, both can be a problem with metabolism. If you have low blood sugar, then your cells are like, hey, where's the other half of the equation? If you have high blood sugar, we know it's not getting into the cells, or else it wouldn't be high. So in either case, low blood sugar and in high blood sugar, it's in or not in our blood, but that's not the real question. The real question is why isn't it in the cell? Why isn't it in the cell? Now, this is easy to determine. If I don't eat the Snickers bar, my sugar isn't low, my sugar is low, and therefore there's no sugar to go into the cell. Therefore, I die. No cellular metabolism. If I eat the Snickers bar and it goes into my blood, that's great. That's a good start. But I don't have insulin, so it doesn't go into the cell. In one case, I have low blood sugar, nothing goes into the cell. In the other one, I have high blood sugar, but without insulin, It doesn't go into the cell. So in either case, low blood sugar or high blood sugar, what?
He said, where does it go? In an instance where you have low insulin and high
It just stays there.
It stays in the blood. That's why it's high. It stays in the blood until your renal system filters it out, and that's why hyperglycemia comes with polyuria. If you have high blood sugar, it means your body can't use it or store it, so it excretes it. You urinate, which is why one of the number one signs of hyperglycemia is polyuria.
That's why people take diuretics.
No. Polyuria is excessive peeing. This is just a document up there. Even they know. They're like, what is that? That's so many words. That's it. All right. Here's what you need to know. Hyperglycemia is too high of blood sugar. Got it? There you go. No, I'm just kidding. Just kidding. Also write this, the polys. P-O-L-Y-S, the polys. When your sugar is too high, it means it's not being used or stored. Are you with me? Alex, what does it mean if your sugar's too high? What do I know? Or used. It's not being used or stored. So what does your body do to deal with it? Well, in a sense, the polys. Polyuria, which we've discussed already. What's that, frustration?
So I'm trying to figure out what's most important.
I'm telling you right now, listen to my words. Come, little one. Follow the pieces of candy.
But it's just like it's not just on the slide, I mean like in general.
Nah, you're wrong.
Right.
You've arrived to find a patient. They're experiencing a diabetic emergency. What should you suspect their sugar to be like?
Low.
Or?
High.
Great. You're like all the way there almost. Now, what do you as an EMT do for high blood sugar? Go on.
For high blood sugar?
Yes, ma'am.
Transport.
Okay. Anything else? No. You have no treatment for hyperglycemia. Okay, so let's just mark off 50% of the possible conditions that might arise in this case. Okay, what condition can you treat? Low blood sugar. What do you do for that? Give them sugar. Well, let's be specific. Glucagon or oral glucose. Okay, so you are arriving to a diabetic emergency. They are either hyperglycemic, in which case you transport, or hypoglycemic, in which case you give oral glucose if you can, or glucagon if you can't. Where's the frustration?
There's so many other words that look so important.
Okay, I have a question.
Yeah.
I have a question about oral glucose, and I think you've talked about this on Tuesday.
Oh my gosh, you're
But,
killing
like,
me.
Sorry.
No, not you.
That's why I said that. Cause
With
she's
the-
gonna write it
Dude,
off.
she can't not.
With the, I feel like I'm getting confused when to draw the line between, like, okay, oral glucose or glucagon.
Okay, here's the line of where to draw the,
We're in Georgia, so
Okay.
no glucagon. I'm just kidding.
For registry.
for registry. If you think there is a choking concern,
Yeah.
you cannot give oral glucose. Now, how that might be described could be a cornucopia of words. So I would say read a test question. If you're like, drooling could be a sign they might choke on it, then don't give oral glucose. If they're lethargic, altered, if any part of you thinks if I just throw a marble in there, they might choke on it, don't give oral glucose.
Yeah. It's
Give-
not a scenario in, like, the lab scenarios. It's like, they're altered, they're, like, lethargic.
You are going to get,
then-
it's not, you can get away a lot easier in a scenario than you ever will be able to on a test. The test is exacting. If you think it's a choking concern in any remote sense, do not give oral glucose. In fact, that's what the register will be looking for, if anything. They won't be looking for, do you know how much to give? They'll be looking for, do you know when to give it and when not to give it? And not, so they're not going to be tricky about, like, a guy is like slightly, I mean, you can give it for confusion.
Right.
Here I am confused. I'm like, I think Mr. Harris is my friend, right? Like, you know, so I'm like experiencing, no, I'm just kidding. I'm experiencing confusion, but I have no level of consciousness degradation.
Right.
I have no choking concern, or at least no more than usual, right? And so that's all you're trying to really determine. On a registry question, are they going to choke on this? Well, if they're drooling or lethargic, that's
Yeah,
easy.
That's way easier.
Yep.
Do you think they'll be
In
questioned?
scenarios, you're going to get, depends on what adjunct you get. They're going to be like, hey, what? You're such an idiot. Why wouldn't you rub it on the inside of their cheek? And you're like, because they might choke. And you're like, why are you, okay.
Yeah. Okay.
I have a question. Like, if we can't give oral glucose but glucagon, like you said something earlier, like glucagon moves sugar. If we don't
Out of the liver.
Like, but if they don't have sugar, then won't glucagon hurt them?
If you're,
How do we know?
you won't. And if they're, that's why go back to your drug card. If the indication is hypoglycemia, not what are their liver stores like,
Okay.
right? Okay. And I don't mean to pick on you here, Haley. Well, I mean, I enjoy it, but that's not the value I'm looking for. What I guess I'm trying to say is be not distracted by all the science. You do know the way through this.
Right.
What I'm trying to help you with is decide, without knowing their sugar, what their problem is. So let's talk about the polys and why.
Why don't they keep the phages together? Phagia was in neuro, and that was slurred speech, and now it's excessive eating. Like,
It is. It's where it belongs. That's why. When you have high blood sugar, your body is going to get rid of it by peeing. So your patient is you walk into a room, a geriatric man is sitting on the couch, it smells strongly of urine in there. Is he hypo or hyperglycemic? Hyper, because that's how our body gets rid of sugar, kind of. When we go into AEMT, I'll tell you how that's not what's happening. But for now, that's what's happening. It involves discussions of oncotic pressure, which we're just not going to do right now.
What about the eating? I feel like if you had
Ooh, this is fun, baby. Oh, gosh. Okay, here we go. You ready? You've got a patient who is hyperglycemic. Why is their body asking for food?
Because they're not using it.
Because they're not using it.
So it's just a symptom, or it's like a
Mhm.
sign.
Their body is saying, my cells aren't getting sugar. We need to eat.
Right.
And the blood is like, yeah, but it's like, hey, shut up. My cells are more important. I'm not getting what I need. And the blood is like, it's like sludge. It's like sugary sludge moving through the vasculature. It's just like, get me a chicky nugget. Right? So we expect excessive eating with high blood sugar. We expect it because their body isn't utilizing or storing it. Sebastian.
So when someone's in like a hyperglycemic emergency,
Yes, sir. When they're in a
are
hyper.
they more like if they're gonna go into shock, are they more like hypovolemic shock, or is it more like I don't know if it'd be distributed because
It would not be distributive. Distributive is largely infection or histamine or vasodilation.
So thick doesn't really have an effect on that. That's kind of where my
I would say no is probably the simplest, easiest answer, that being hyperglycemic has no direct correlation to shock physiology or presentation.
even with the excessive urination of oxygen to tissues.
I think there's a reasonable conversation to,
Because you're losing the fluid.
I think my over-dramatization of saying sludge moving through your vessels is giving the wrong image. It still flows like water, but it is definitely thicker than normal blood, which leads us prone to atherosclerosis, not obstruction.
That makes sense.
Yeah. So when people say like, oh, well, high blood sugar leads to hypertension and renal failure and optic nerve destruction and seizure and stroke and all this stuff, they'll tell you, oh, it's because the molecules are big and they're clogging things. No, they're not. They're causing what's called glycation of the vessels. It's making their proteins adhere. So in summary, it's not causing... You frustrated with the lab?
No.
Oh, okay.
I heard something very funny.
Oh, okay, great.
In my ear.
Got it. I can't not think. Okay, let's see. So you aren't hyperglycemic and then getting clots. That's not what's happening. You are getting hyperglycemic and it's causing atherosclerosis, which will then cause clots. It's not like you just have like a bundle of sugar that just gets clogged somewhere. It's not like I cut my wrist and it just drips out because my sugar is so thick.
So is that why a lot of diabetics, do they stay in the hyperglycemic state for so long? That's why they lose limbs, toes?
Yeah, that's why. because I used to just say when you have too much sugar, you get acidic and then it destroys all that stuff. And that's like not true, but it is an easy way of remembering it. If the thing is it's almost like if I wanted to draw a line, like you and I, as non-diabetics, as our sugar level goes up, so does our insulin. So we never really stay. It's just this kind of even up and down experience. Sugar goes up, so does insulin. It brings it down. Oops, stops insulin. Sugar goes up, and we just chill at this level. But a diabetic who can't make insulin eats, takes insulin, goes down. Eats, sugar goes way up, takes insulin, goes way down. And so they live way more often in a hyperglycemic state than you and I ever do, which means their blood is thicker slightly, and they are more prone to atherosclerosis, which means they're more prone to hypertension and stroke and seizure and all kinds of manner of things. Okay. Go ahead, Stephen. Unless you had more. Okay.
Why does that cause them to like lose limbs and stuff? Is it just because the tissue dies because it's not perfused?
Perfect. Yes. Lovely. Well done. Yeah, we have in our optic nerves and in our renal tubules where it gets real tiny. When you live in these acidic and I don't want to get into acidity yet because that's more with ketosis, but in short, when your sugar is high, it destroys small vasculature. If it destroys it in your eyes, it's why we see hyperglycemic patients and diabetic patients lose vision often or have visual deficits. It's why we often see them with high blood pressure because it destroys a lot of our renal function because it gets real small in there. And in summary, because if you live without utilizing your sugar, your body goes into DKA more often than never, and ketones are acids, and that will also destroy vasculature. But if I'm looking at this, what I really want you to know is what the word paresthesia means, numbness and tingling. I want you to know that that having chronically high blood sugar causes vision loss and organ failure, especially in the kidney, and it just having high blood sugar makes you prone to all other conditions basically because of the destruction of the small vessels and structures therein.
Why do people take it so lightly?
Because it is known and it is common.
You said any other condition due to vascular destruction, not like.
Basically.
I just wanted to.
Yeah.
Right there.
Your sugar's high, it ruins your kidneys, it ruins, honestly, everything. Because what did I say? It causes the glycation of the vasculature. Somebody points to their body where there isn't a vessel. You know what I mean? Yeah, I guess you got capillaries there. Look, if you didn't have vascular there, blood wouldn't go. Arguably capillaries? Is that your fingernail? Hair? Is your hair your body? I don't know. But my point is it's difficult. And this is fun. Point to your cartilage without also touching a place that's infused with blood. Just stay on the outside. All right. Okay, so I think, did we fix this or you okay? Okay. So, yeah. Well, let's play and we'll test. Okay, your patient has polyuria. What does it mean?
Polyuria is urination.
Okay, excessive urination. Why is that a sign of hyperglycemia?
Trying to get rid of the sugar.
Yeah, which is our EMT answer. It's trying to get rid of the sugar. The truth is it just, that's like saying, why did water come out when I do this? Well, because it's trying to get rid of it. I'm like, no, that's how gravity works.
It just does.
Sugar molecules are big, so when your body excretes them through your renal, it just takes water with it. It's not trying to get rid of water. It just happens. Okay. I don't know why it's like a Mr. Fearon pet peeve, but it is. Anyway, they're like, anyway, they're just going to pee it out because your body's trying to say, I'm like, nope, that's just physics. Anyway.
Do we need to know the acidosis for hyperglycemia, or is that for? Well, I guess
It's for DKA specifically.
Okay.
Maybe. Okay, polyphagia. Why on earth would a person with high blood sugar crave food?
Because the sugar's not being put into
Used or stored, right? Yes, I have high blood sugar. That's not helping. Now, polydipsia is saying excessive thirst. Why would a person with high blood sugar be very thirsty?
trying to dilute their thick blood.
It is not solution to pollution dilution stuff. That's for toxicology. Pam, girl, get it.
Is it possibly because of the constant urination?
Because you're dehydrated.
Oh.
Because, is that where you're at, Sebastian? I knew it. Because if your body is excreting glucose, which is making water follow it, you're going to be thirsty.
Yeah.
So I walk in and a person is like, oh, I just don't feel good, dude. I don't know, it's a flu or whatever. Lung sounds clear as a bell. I'm like, ooh, you're hot to the touch too. You do feel kind of sick. Check a sugar, 600. I'm like, quick question. Have you been especially thirsty lately? Yes, dude. I'm thirsty now. How's your pee been? You start to see why we keep telling you to ask about urination, defecation stuff? I'm like, shh, it'll be important later. Just do the habit now, right? Yeah. Now, Steven? Dude, you are like clued in on, this is like the most, this is a Steven lecture, dude. I love this.
Is that the only reason for excessive drinking for being dehydrated is because of urination? Or is there something else, anything else?
The number one symptom, or one of the earliest symptoms of dehydration is thirst.
Right. Well, I'm just saying, is it only because of polyuria?
No.
The only reason that...
It can, usually people are thirsty because they have too much out or too little in.
Okay.
If you stop drinking water, you're going to get thirsty. If you pee too much, it doesn't matter how much you drink, you're going to be thirsty. So people are thirsty because they're either low volume or low intake, low volume. If you're not drinking enough water, you get thirsty. If you're peeing too much, you get thirsty. Cool. Now, with hyperglycemia, right? Almeida, what do you know in a person with a blood sugar of 400? What do you also know? Ugh, that's so ambiguous. Probably a lot, is my hope. But I guess let me just tell you what I know.
No, I'll
What do you know?
Oh,
They're hyperglycemia. Well, make up your mind here. I can't. No,
Okay, they're
no.
hyperglycemia.
They're hyperglycemia. What else do you suspect?
I suspect that they're urinating a lot.
The polys, very good.
They're also excessive eating and they're dehydrated.
Yeah, all these things. What do you suspect about their cellular metabolism?
Oh, their body is craving sugar because the sugar is like can't process, I guess.
Yeah, their body is craving sugar because they can't process it. That's the dysphagia. Let me ask you this. A guy's got a blood sugar of 400. Are his cells metabolizing? No. Amazing job. Great. Because they are not doing that, he is going to crave food, right? He is also going to not pull... What do I want to say? I think I just want to cut to the quick. If you're high blood sugar, we know your cells aren't metabolizing. And so how they get energy is by destroying that third bucket.
Oh yeah, the fat.
They break down your fat because in your fat are ketones. And ketones are a less efficient way of making energy. Glucose is what we want. But since glucose requires insulin, I'll use ketones instead. They don't. It will kill you, for sure, but you'll live for a while.
So in like that in hyperglycemic patients they can't produce enough insulin, right?
I can say for sure that if a person is hyperglycemic, they probably don't have insulin, or else their sugar would be regulated.
That's why they use the ketones.
So they break down the fat because the ketones, which will help them, which will make energy, don't require insulin. So I have high blood sugar. Solution? Insulin, ideally. Well, my body can't make insulin. It killed the islets of Langerhans. What it can do is take from my admittedly very limited fat stores, right? It goes over there, it grinds up my fat, and one of the most important things that comes out is ketone. It throws that in the furnace and it lights it on fire. Boom, I get to live. Glucose is not an acid, but a ketone is. And so as much as I'm now alive because the ketones are using energy, they're also making me acidic. And you can practice at home, but pouring acid on a cell will destroy it. How do you practice? Cut open a battery, I don't know.
Drink it.
Yeah, check Amazon. Okay. So DKA is not just hyperglycemia. You can be hyperglycemic without DKA. If your sugar is high, you're not in DKA because your sugar is high. You are in DKA because your body is breaking down fat and it's releasing ketones, which is good because it uses that for energy, but it's bad because it makes you acidic. Are you with me? Are you, Steven?
Yeah, I have
Notes on notes.
Yeah. I
Okay.
have questions.
You've yet to ask a question that I thought was unwise or not worth time. So
You said it's good because they get energy, but it's bad because why?
without energy, you would die. Yes.
Yeah.
Okay. But you have sugar you can't use. That's no energy. So your body says, "Oh, I can get some energy. I'll break down my fat."
Oh, that's okay.
And it's like, "Oh, ketones as energy? That's awesome." And it's like, "Yeah, dude." Oh, one little thing. It's also an acid, and that'll kill you. And you're like, I don't want it then? It's like, okay, well, then you die from no energy. But you really get to pick your poison here, right? Well, you don't get to pick. Your body does it for you. Okay. Ketones are like acetone. Rubbing alcohol, they'll say fruity breath. It has never smelled very fruity to me. You know, nail polish remover is an acetone. What that smells like, ketones smell like that, and they're coming out of people's mouths.
So it's not like fruity. It's like the nail polish.
Yeah, I think there's a sweetness to it. To call it fruity is a bastardization of all fruit I know. That's like smelling a musty wall and being like, oh, that's like a watermelon. You're like, no, there's a sweetness to it. It's not fruit. Yes, dude. The only other time I've smelled that is when people try to OD on Robitussin. And it's just that sickly sweet, like alcohol-like, okay? Now, be careful here. I also heard this incorrectly in the lab. If you have fruity breath, it is like dead nuts DKA. Not much else does that unless they just drank some weird fruity sicky thing. But not having it doesn't mean you're not in DKA. Sometimes you don't smell it. Sometimes it's not very strong. Now, I've heard different in my own class where somebody was like, they don't have fruity breath, so now you know it's not DKA. You don't know that. Okay? If you do smell fruity breath, it's pretty dead giveaway. Guy walks up and he's like, hey, I saw this in a courtroom. I was doing my stop sign thing. And a guy was sitting on that thing and said, hey, brother, you okay? You look like you're a court low. He said, man, I just don't feel good. And I was like, whoa. I was like, are you diabetic? And he said, yeah. I said, okay, somebody needs to call an ambulance for you. You're in DKA. I was like, paramedic. Yeah. Anyways, I went and paid my ticket. It sucked. Go ahead, Steven.
So when people are on like the keto diet,
Yes.
uh,
Do they get fruity breath?
I
Yes,
don't know,
they
but
do.
so you're
They do.
constantly putting yourself in-
A state of ketosis. Yeah.
So why is that not just killing people?
Because you can survive it. All DKA patients don't die. It's just not good for them.
Just not, or why are they saying, oh, it's a healthy?
Well, I don't know that everyone is, or if they're correct in saying that. But what I can say is this: some of us got ketones to spare, and being in an acidic state is not great on a long term. But you know, I go on a decent crunch, burn up a bunch of fat, process the ketones, feel a little weird for a few days. I don't think it's crazy. But living in that state, not good.
Now there's some people who are like, oh, the keto is way of life. It's like,
Yeah, my guess is they're not actually in ketosis, like, you know, in acidosis. They're just burning up, you know. But I've also, chances are, if you can smell that person's fruity breath, they're probably going to the hospital. They've done it too. They probably look great in a dress, but better in a casket. Yeah.
At what point?
really great in their medical gown.
Yeah, like, oh, it's not open in the back. Yeah. Yeah, you can see all my bones. Yeah.
No, that's what I was thinking too, with the whole ketosis or keto diet.
Yeah.
It's like, why would you want to,
Put yourself in that state.
if it's,
Because all things in moderation, my son. I mean, we're getting the ketones because we're burning fat, and that's awesome. You live in that state, not healthy.
At what point does DK turn into like a diabetic coma? Because my grandma went through that, and I'm just curious.
Yeah. Let's see. I don't think I really didn't start doing these like little breakdowns until the short version is that we would expect DKA stuff to happen within a day. So when would DKA put you in a coma? Well, 1 to 24 hours, something like that. HHNK, what we'll talk about next, or HHS, or HONK, or any innumerable amount of things, that takes far longer. So the DKA, hyper or hypoglycemia? Hyper. Very good. It is commonly associated with infection because as your body fights infection, it releases adrenaline. And more probably to the point is cortisol. And that works against insulin. If you're looking at that sentence like, oh my God, so many words, remember this. Infection associated with hyperglycemia. And you already kind of can make that association. Infection is largely associated with hyper or hypothermia. Hyper, mostly. Hyperthermia, hyperglycemia, affection, boom, let's move on, yeah? Love it. Small respirations. We all know what it is by now, I think. Fast, deep breathing, because we have two ways of balancing our pH. One is through our kidney, that's metabolic, and one is through our lungs, our respiratory. CO2 is not an acid, but it creates carbonic acid. I think it's just kind of easier to incorrectly think CO2 is acid. If I breathe out CO2, my pH goes up because I'm breathing out an acid, let's say. In short, it sucks to die, or so I've heard. And so I don't want to do that. I'm going to burn up all my fat to use that ketone as energy. Well, ketones are acidic. It will put me in an acidic state. And my body can balance that out by blowing out the only acid I can control quickly. So as my ketones rise, so does my level of acidity, which means my pH is dropping. And so I blow out CO2 to get my pH to a normal level because I'm having too much ketoacidosis. That's what Kussmaul's is doing. Or in summary, if you find a person with Kussmaul respirations and you try to coach them into slowing their respirations down, that is catastrophic for them.
So you just let them breathe fast?
Yeah. Sam?
So if I ran a call and the patient was...
You're supposed to say, if I had a friend. I have a friend that ran a call.
My first thought would be hypoglycemia.
Say what you said again?
If they were lethargic or unresponsive, I would think hypoglycemia.
And I think that is correct.
Blood pressure,
Sugar?
if it was high and they're acting like that, would I just assume DKA or would I try to look for more?
So, unless you misspoke, I think I only understood half of that, so I'll talk for a little bit. You let me know if I didn't solve the problem. There is no better way through all of these constellation symptoms than checking a blood sugar. Almost nothing causes your blood sugar to go so low. Let me see. How do I want to phrase that? Almost nothing causes all of these symptoms while your blood sugar is low. Usually all of these symptoms are because your blood sugar is low. Meaning if I walk in and I'm like, whoa, you are all messed up and your sugar is low, I'm like, oh, okay. I'm going to give you sugar, and then all of this stuff is probably going to correct itself, and that's almost always the case. If you have all of these things, you're hypertensive, you're all these things, I'm like, dude, what is this? Like a thyroid issue? Like, man, is this a stroke or whatever? And I check your sugar and it's high. I'm like, oh, well, okay. It's probably just high blood sugar. And part of the reason for that is it is so integral to the cellular metabolism that it affects everything. And so to repeat your question back to you, Sam, something along, you said hypertension. Is that what you meant?
No. I was thinking the unresponsive lethargy.
Yeah. You walk in, a dude's unresponsive and lethargic. You're like, low blood sugar. And you should.
It's high. It's not just hyperglycemia, it's DKA.
My man. I might be hyperglycemic right now. Whatever. Ketoacidosis is a very different animal. That means I've been high blood sugar for a minute. Or more to the point, regardless of the blood sugar, I have been without cellular metabolism for a minute, 1 to 24 hours. So much so that my body says, okay, I will not stand for this. Let's burn up that booty and use them ketones to live. So if I show up and a person is unresponsive, my first thought is like, whoa, stroke, heart attack, hypoxia, or sugar. And I'm definitely thinking all these ultra level of conscious stuff is low blood sugar, but the skin will point me in a direction for sure. Cool and clammy, give them candy. If they're cool and clammy, I'm thinking low. If they're hot to the touch, warm, red, erythemia, these type of things, I'm thinking DKA. But in any case, whatever I thought, with my dark rim glasses and years of experience, if I check that glucose and it gives me a number, we're going to cut right to it. Landon?
Is DKA the only thing that will present with lethargy with hyperglycemia? Is that a like straight cutoff?
No, it won't. HHS will.
Oh, that's right.
There are two primary conditions that are a level above hyperglycemia that we need to be aware of. One is DKA. The other is what I prefer to call as HHNK. The book says HHS, I think. But these three names, HHNK, HHS, all these, it's just, you're just watching the medical community make decisions over time. It's all the same thing. We have we've got like euglycemia and hypoglycemia. That makes sense. It's either too little food or too much insulin. Easy correction in many cases. Hyperglycemia has levels above it. Now, I think that we shouldn't view it like hyperglycemia and then one condition and then another condition. It's better to view hyperglycemia as a branching pathway. That HHS and DKA are very different experiences. They are not on the pathway to each other. In short, DKA is what you get when you got diabetes 1, because you don't make insulin, so your body burns fat. HHS is what you get when you have diabetes 2, because you do make insulin, so it does not need to burn fat. The big difference here, and the reason why I prefer HHNK over all the rest, because it's eponymous. It says it in the name. Hyperglycemic, non-ketotic. DKA is ketotic. So the difference is they are both hyperglycemia. One of them involves ketones. The other is hyperglycemia without ketones.
So what do they do then? How do they get their energy if they can't? Oh, because they already have insulin, right, from the diabetes too. Because they can produce insulin.
Yeah, but in something is wrong though, and it's probably the descent. So, Roman, your patient, I said it fast, but we'll see. Your patient has diabetes 2. Do you suspect HHNK or S, I'll use these interchangeably, forgive me, or DKA?
HHS.
My man, why?
Because DKA, he was in Kuzmal respiration. I'm a little unclear.
That's okay. I think you're close. Tell me, so you got a patient with type 2 diabetes. Do you think DKA or HHS? You think HHS because type 2 still makes insulin.
Hard and fast rule.
Bingo.
Sweet.
So is that something you will?
But they don't use ketones.
That knowledge is
Oh,
huge.
because they use insulin to get their energy, or the insulin turns into glucose, which gives them energy.
Sure.
I don't know.
Okay, I have one more.
Never mind.
Sure. No, you're close enough.
If someone's like lethargic or unresponsive, can they still present with Kuzmal respirations?
If somebody is oh yeah, like somebody could be in DKA, completely unresponsive and yeah, because their body's buffer system is going to take over without their.
It's so weird to think about like somebody lethargic and hyperventilating.
Yeah,
Strange.
it is super strange. But thankfully, you walk in and you're like, oh, I know what this is. Because your brain is instinctively doing this Rolodex thing, right? Like I say, your patient's unresponsive, what do you think? And you're like, dude, anything? Okay, now you start your patient assessment. What is their airway like? Clear. What is their breathing rate like? 40. Unresponsive at 40? Is it regular? Yes. What's their skin like? Pale, cool, clammy? Nope. What's their sugar? That's why I'm like, I have a pile of labs that kind of move through where if you're like, I'm gonna do my ABCs and then check sugar. It's like, well, there goes the fun. Okay, so DKA, free breath. You got tricky test questions coming. You listening? It paints all the picture of DKA and specifically says no fruity breath. Could it be DKA?
Yes.
You're gonna do fine.
Yes.
It doesn't always have fruity breath. Is my breath fruity? Huh? Does my breath smell fruity?
No.
Look away from the man and just take in the breath. You didn't smell it, right? Let me ask you this, right? You can't palpate a pulse. Are they in cardiac arrest?
Not exactly.
Maybe.
Yes.
No, maybe you missed it.
I don't know. Never mind.
Maybe their blood pressure's so low you can't feel it. Maybe you're feeling it in the wrong place. You see the language I'm using? You don't smell fruity breath. Could it be DKA? Yeah, they might have fruity breath. You didn't smell.
But they might not, and they can still be DKA.
Bingo.
Okay.
They might not. Yes.
So it's only an indication, not a cause.
It can be a diagnosis of inclusion, not exclusion. Also, you got to get in there for DKA fruity breath sometimes. I mean, in there. I've not worked with many partners that will smell for it because you got to get in there.
Well, I smell something else.
Yeah. Well, you smell the pee big time.
In the breath.
Not in the breath, girl. Immediately understand. A lot of your character makes sense now. No. No, you can smell it because they got polyuria. They just can't stop themselves from urinating all the time, and it smells sugary. In fact, oh boy, this is fun. What does the word diabetes mean? Anybody have any idea? Oh no, I don't remember what it means. Move through? I think it means move through. Flow through? Hit me? Are you looking, Sam? Diabetes means something like that, to flow through. I think most people think diabetes means sweet. It doesn't. Mellitus means sweet. Oh wait, is it taste? Yeah, etymology with a Y, E-T-Y, etymology, diabetes. Anyway, the point is this. Guess how they used to know if you had diabetes? They tasted your pee. To go through. Yeah, okay, I was on.
They tasted their pee.
Because nothing makes your pee sugary unless you're diabetic, basically, and you can smell it. I don't.
They paid them $1 million.
Doctors get a lot of money. Because I'll say this. I don't think I've ever found a DKA polyuric patient and been like, I should really taste it. I mean, I can smell it, but I got to get in there. Look, Sebastian, some of us are committed to the job. Okay, some of us are excellent patient.
There's someone who did all the stuff.
Yep.
Drinking milk.
So, one day there was a weird doctor,
Yeah.
and he turned out to be a genius. Yeah. It's you got to get a good bouquet going. Cracker in between. Yeah, no doubt about it. But like I said with lung sounds and EKGs, like you got to get used to normal so you know pathology. So this is why I recommend that you just taste all urine so that you can say, hey, that one's not normal. Also, please don't taste pee. Okay. Ooh, I love this house. It's my favorite. Okay. The big takeaways. Oh boy. Oh, that was beautiful. Sweet pea. Sweet pea. The way you get through this is thus. Hyperglycemia, DKA, and HHS, or whatever variant you're using, are all high blood sugar. One can have fruity breath. The other two never will. One, DKA can happen within a day or so. HHS is far more profound and can take up to, a week. HHS doesn't have ketones. They are not acidic. That's DKA. But they can be profoundly dehydrated.
Just normal respirations for this,
Can't they all
for
be
this guy?
dehydrated?
Yeah, they can all be dehydrated.
Oh, there's it. No.
What's up, Henry?
What's that word? Hyperosmolar.
Make a fist. Okay, now make an open hand. Which one is bigger? Your open hand is bigger. The natural physics of the world is based on oncotic pressure, where water follows the big thing. If your open hand is sugar, where does the water go? Where the sugar is. Your kidney will get rid of sugar, so water follows the big molecule. So hyperosmolar is saying because you have a lot. No, it's not foolishness. This is deep water, brother. Because you have a bunch of sugar in your vessels, you are in a hyperosmolar state. And the only reason why they drop the NK part is because they're like, what else would you be? It's non-ketotic. That's DKA. Now, here's the wrong answer on the test. Diabetes does not mean sweet. It means to flow through. Insipidus means something I don't remember. Oh, no taste. That's what it means. Does it say it on there? No, okay. Insipidus means no taste, because mellitus means sweet taste. This is a very different problem. This isn't something we need to understand as EMTs or AEMTs. It is the wrong answer on the test.
I'm putting that in my notes.
Good.
As you should.
Diabetes insipidus means you have a condition where you're not producing enough of a specific hormone that helps you regulate your urination. Diabetes insipidus, they pee too much. They become dehydrated. Oh, tasteless. There it is.
Okay, great. We got 8 minutes.
We got 3 minutes.
Now.
You're coming to the end of your book there,
Oh,
bud.
3.
Do you want to talk about angiotensin aldosterone system?
Basic. And then you could
It's going to be on the test.
No.
Great.
You said you'll update like the slides and then.
I'm going to huh?
This is a good PowerPoint.
You'll post slides.
This is good. You
Well, I
don't
just
worry
want
about that.
like
Yeah, but did you see, like, there's like a third of the room. They're just like, brain, melt, words. And I'm like, I know, I'm so sorry.
I just want it like posted with like the lecture because I feel like I like looking at something whenever.
Just look at me. Why don't you like looking at me?
No, I do.
What's wrong with that?
Whenever you like.
Didn't you see my fruity breath expression?